So we'll quickly move into the next lecture. The lecture will be on the cardiac involvement in COVID-19 infection. So I would kindly invite Dr. M. Saki, consultant cardiologist, for his lecture. Over to you, Saki.
Good afternoon, everybody. I think it's a post-lunch. Most of them are either sleeping or hyperglycemic or I don't know what they are doing. Anyway, it is my duty to deliver the lecture as per the request by the Heart College of Cardiology. Anyway, it should be an interesting topic and contemporary. So it is better to listen to some of the points which I am trying to say. So COVID-19 involvement in, cardiac involvement in COVID-19 infection. So the outline of the lecture would be just some introduction to the COVID-19 and biology, a little bit of boring topic, the biology of SARS-CoV-2 virus and the common symptoms, followed by that cardiac involvement, CVD and COVID-19. We'll get to the proper topic. Later on, we'll describe about the common cardiovascular manifestation, and there's a lot of controversy and talk going on about AS2, which is the molecule where the virus attaches itself and go into the cell, and we'll talk about a little bit about that, and finally, how we are going to live with this pandemic. I think it seems like it is not going away with any soon, I think. So COVID-19, as you all know, it is caused by SARS-CoV-2 virus. It's a coronavirus, probably originated from bats. And there are a lot of controversies on where it is really originated. But bats are supposed to be a big reservoir for all sort of coronaviruses, right? And it is first reported in Wuhan, China in December 2019. I think previously in the early 2000s, I think we all know the SARS virus which came, which is very close to related to this virus which we are experiencing now. If you take the genomes, there are about 80 to 85% similarity between the SARS, the initial virus, and what we are experiencing the COVID-19 virus. The pandemic is now affecting more than 200 countries, and it affects on public health, social, economic. I think we are all experiencing all these effects from the COVID-19. So this is this morning as it stands, the statistics. We are in Sri Lanka. I think we have about 5,625 cases with 13 deaths. We have done, I think, one of the either first or second in the world. We have done our best. Hope we will continue that in the future as well. And unfortunately, world is not doing very well. So we have about more than 40 million cases confirmed this morning. And death is passing more than 1 million. And recovery is around 27 million. So this is today morning around 7 a.m. Right? So it is a real problem. So it generally causes a respiratory infection which leads to a viral pneumonia. That is the basic pathology leading to ARDS. You all know the acute respiratory distress syndrome, where it looks like this pulmonary edema, bilateral sort of shadowing, white shadowing in the chest X-ray. And there are other parameters to diagnose ARDS. And it can also trigger something called a chemical reaction, where it calls a cytokine storm. I think many of us already would have heard about at least TNF-alpha. And these are all comes with the inflammation, and which is the one which causes multi-organ failure, it seems, right? If you ask me really, is there any evidence-based? Yes, there is yes and no sort of answer, because COVID is still very new to us. So there are more questions than answers for many of the questions that we are facing at the moment, right? So these are also postulations, but it looks correct so far. So cytokine storm is the one which causes multi-organ failure. That means the, AKI or liver injury or heart problems, those things can be due to cytokine storm. Secondly, there could be a coagulation problem. The coagulation is, as you all know, more toward either, if the coagulation goes abnormal, either it could be bleeding or thrombosis. But in COVID cases, it is mostly the coagulation problem leading to thromboembolic phenomena, more thrombosis. So the patients can develop manifestations of both arterial and the venous thrombosis. At present, there's no preventive vaccine or prophylactic therapies, unfortunately. So it is all mainly supportive and some sort of trial and error sort of management that we are going on at the moment. So biology of COVID-19, as you all know, it is a coronavirus. It is a family of a single stranded, it's an RNA virus. You know, viruses could have either DNA or RNA. In this case, the coronavirus is a RNA virus. The virus, the pictures there, don't get scared about the corona picture. So it has several structural protein. There are S protein, M protein, E protein, ssRNA, and the N protein. These are the main structural protein of the coronavirus. And out of that, the most important protein is the S protein, where it attaches itself to our host cells and enter into the cells. So the S protein is the one which helps the virus to enter the cell. So the S protein has a crucial role in the virus attachment and entry and the disease pathogenesis. All this is now postulated, this S protein is important. So the binding of the S protein to the AS2 receptor. The AS2 is the enzyme, as you all know, angiotensin converting enzyme 2, which is the one triggers the virus entry into the cell. And there could be two pathways. Either once it attaches the virus to the cell membrane, it could pass the RNA directly into the, inside the cell, or it could, the virus in the membrane can endocyte. So it can go into the whole virus can go inside and later on release the RNA, then produces the new viruses. So this is a bit of a complex sort of diagram. To summarize that, either it could attaches itself into the virus cell membrane, and only the RNA can go into the cell, or it attaches itself to the cell membrane and the whole virus and part of the membrane will go in. But ultimately, all this process will go in, produces a lot of new viruses. So I do not want to describe all this part. So it attaches itself with the S protein with the help to the AS2 gene. Either it releases RNA only or the whole virus go in. Ultimately, multiples of that will come out. So that is the basic pathophysiology, how the virus life cycle. Before I go to the cardiac manifestation, it is very imperative that to get this message across, because more than the cardiac problem is a presenting symptoms, the symptoms of other symptoms are very common. So initially the fever, fatigue and chills, the commonest symptom of the COVID-19 is fever, 88%. The next commonest sign is dry cough. 68% we have dry cough. And apart from that, there will be fatigue, chills, headache, nasal congestion, sore throat, and productive cough, dyspnea, nausea and vomiting, diarrhea, myalgia. All these could be, as for any other viral illnesses, these symptoms are very common. And there are some peculiar, sort of rare symptoms also can come, like loss of taste, or even loss of smell, right? So recently I read some interesting post in the Facebook, but they say the husband came and said, food was served by the wife said, and the husband said the food is very, very untasty, can't eat, what you have made for me for the lunch. And immediately the wife called the 119 and said, the colic task force, my husband has a loss of taste and please come and pick him. And immediately next 2 hours or so, husband was taken for 14 days quarantine. And the wife was relieved. So be careful, gentlemen, right? Whoever is listening, the husbands, be careful about this, complaining the food and other things, right? So the cardiovascular system and the COVID-19, both the susceptibility, that is whether you get the infection or not, or if you get the outcome. If you get the infection, how badly it's going to affect you. So both of that is related by cardiac disease. So if you have pre-existing cardiac disease, you are more prone to get COVID-19 infection. And if you do get an infection and if you have a cardiac disease pre-existently, you're going to fare bad because of bad prognosis. So the cardiovascular disease, hypertension, and diabetes were common pre-existing conditions, right? And the prevalence, that means if you have a bad diseases in the past, already if you are having these diseases, you are more prone to get the COVID-19. The prevalence was higher in critically ill patients and in those who died, right? The prevalence means the cardiovascular disease prevalence was higher in the critically ill COVID patients and those who have passed away, rather than those who had the milder disease. The cardiovascular disease increases the mortality in patients with COVID-19. So the diverse cardiovascular manifestations can occur. It is not only one, right? The cardiac symptoms may be the first presenting feature of COVID-19. Sometimes the patient can come with a chest pain or a heart attack or even cardiac arrest as the first presentation of COVID-19. We'll see how it occurs. And the systemic inflammation accelerates the development of subclinical disorder or cause de novo cardiovascular damage. Sometimes if there's a subclinical disease with this excessive inflammation, it can come with acute coronary syndrome or heart failure or something like that. Or even there are mechanisms now we have identified that the COVID-19 can cause the new cardiovascular disease as well. So the COVID-19 can cause myocardial injury, arrhythmias, acute coronary syndromes, or even thromboembolic phenomena. So in children, as you all, who works with children, the pediatric wards, I think you all might have heard Kawasaki disease, where these big coronary aneurysms can occur and the patients can sometimes die, either due to very young age myocardial infarction, or they can even rupture and cause pericardial tamponade and death. So COVID-19 patients in young children, it was initially thought it is a very mild disease and very safe for children, but unfortunately there are clusters we have identified now that in young children with COVID-19 infection, Kawasaki-like disease has occurred in these children, especially in UK there was a cluster and there was one in Italy as well. And so there is something called a bidirectional relationship between cardiovascular disease and the COVID. That is, if you have cardiovascular disease, you are more prone to get COVID-19 infection. And if you do get COVID-19 infection, then you are more prone to get cardiovascular disease. That is what the bidirectional, this is a very busy slide, but I'll just cut short. So this is the relationship that we are telling, the bidirectional involvement of COVID-19 and the cardiovascular disease. So one side it is cardiovascular disease, what we are talking about is hypertension, coronary artery disease or diabetes. Other side it is COVID-19. So if you do have these comorbidities, your susceptibility and the severity of the disease is more, right? And you are more prone to get heart failure as well. If you do get COVID-19, it comes, some of the blue arrows come to this side. It can cause acute myocardial injury, myocarditis, acute coronary syndrome, arrhythmias with long QT, VT, AF, VF, everything, and thromboembolism, right? So this is the bidirectional involvement. If you do get COVID-19, cardiovascular involvement, cardiovascular disease, more prone to get susceptibility and the severity of COVID-19. In addition, if you get later on the acute ARDS, and there's a lot of systemic inflammation come, that is the one I was talking about, the long-term effects, thromboembolism, all this come due to this systemic effects. A lot of arrows are coming this way. And further, there was some postulation because our communities, we have a lot of heart disease and hypertension and diabetes. I was talking about ACE2, the enzyme, where the virus goes and attaches itself. So we are blocking ACE by ACE inhibitors like enalapril, captopril, ramipril, or even losartan things. So that is our preniningiotensin system. We are blocking with these medicines, right? Whether it has an effect really on COVID-19, either severity, whether it is bad or good, it is really, we don't know, but the consensus I'll come tell later. What they say is it doesn't affect too much about the COVID infection. So myocardial, I'll quickly go through some of these major conditions where how it affects the cardiovascular, the COVID-19, how it affects the cardiovascular system. The number one is myocardial injury and the myocarditis. So the elevated level of cardiac markers like troponin or even CPK or sometimes D-dimer, there could be ECG changes. So this all indicates even the LV function might be normal, but these enzymes, the markers can go up, and the ECG, there could be changes. There are two mechanisms against what I say. It could be due to cytokine storm, or it could be directly infecting the myocardial cells. Right? If it directly involves the myocardial cells, it causes viral myocarditis. But as it stands, the current evidence here, myocarditis is very, very rare in COVID-19. The first postulation is more common, it seems. Right? They associated with need for invasive mechanical ventilation, it increases the mortality. If the patient has myocardial injury, it increases the chance. If the troponin I is high, you will end up in more chances of either ventilation or even death it can cause, right? Compared to the patient who doesn't have increased level of troponin. An independent risk factor for in-hospital mortality is a myocardial injury, right? So you are more prone to die in hospital with COVID if you have a myocardial injury. Troponin has a predictive value for risk of in-hospital mortality. So if the troponin is elevated, you are more prone to die. Acute coronary syndrome. So COVID-19 can trigger acute coronary syndrome. The underlying mechanisms are it could cause a plaque rupture, coronary artery spasms, microthrombi, owing to systemic inflammation or cytokine storm, right? And direct endothelial or vascular injury also can occur with COVID-19, and the risk of thrombosis, thrombus formation and the acute coronary syndrome is also there. And the acute coronary syndrome, but the number of reported cases, this is an important phenomena, right? We told the public health effect of COVID-19 because a lot of patients, although they did have the coronary artery disease or acute coronary syndrome, they did not come to seek medical treatment. So some of the patients would have died even in the community with the acute coronary syndromes. So what they say is the number of reported cases for ACS are significantly lower in the COVID period. By contrast, the incidence of outpatient hospital arrest has been increasing, right? So this tells the story. Patient is scared to come to hospital for treatment of acute coronary syndrome. The number of patients with myocardial infarction seeking urgent hospital care declined by more than 50% in COVID infection while it was peaking, right? So this is just for completion how we are treating the STEMIs in COVID era. If we are having a lot of COVID patients in the community, how we are going to treat. But only thing what they say is these all European ESC guideline. What they say is only hospital equipped to manage with COVID-19 should maintain 24/7 cath lab services. But unfortunately in Sri Lanka, I don't know this is how much we apply to this, because how much we are prepared for managing COVID-19 patients in the proper way and going for the PCI and stenting is a question. But fortunately so far we are able to manage the community level COVID-19, so still we are managing. But if it comes to community level and spread very fast, then we might need to adapt these sort of guidelines according to our need. So this is non-STEMI and STEMI. For the completion's sake, I put this up. Not going to describe this. Next one is the heart failure. The most common observed complication of the COVID-19 is the heart failure out of the cardiovascular. So how do you identify? You can do the echo and identify heart function. In the blood, you can check the BNP levels, right? Sometimes there could be preserved LV function with elevated BNP level with symptoms, right? So the heart failure could be due to exacerbation of pre-existing condition. So if the patient already has heart failure, treated with medicine stable, with COVID-19, they can worsen. And uncover the subclinical cardiac dysfunction. Sometimes patients are, without knowing, they might have heart failure, right? Ejection fraction 45, 50. But with the COVID infection, they can come as a outward cardiac failure. In elderly patients with reduced diastolic function, you know, with age and hypertension, diabetes, we have diastolic dysfunction. Pumping is good, relaxing is a problem. So these patients with COVID-19 can come up with fever and tachycardia and other things. They can come as heart failure. Then it can induce, as I said, acute coronary syndrome and myocardial injury with a heart failure can come. Or it could even develop stress-induced cardiomyopathies, right? arrhythmias and sudden cardiac death. The arrhythmias and sudden cardiac arrest are common manifestation of hospital COVID-19. As I said, the out-of-hospital cardiac arrest has been increasing during the COVID era. And the heart palpitations have been reported to be presenting symptom of COVID. Right? Both ventricular and supraventricular arrhythmias and atrial fibrillations are known to occur. So it is induced by elevated levels of troponin due to myocardial injury or ACS, or it could be due to sepsis, fever, hypoxia, and electrolyte imbalances. Or it could be even antiviral medicines. You know, there was a saga about a combination of chloroquine and azithromycin, which prolonged the QT interval and causing polymorphic VTs. So coagulation abnormalities can occur, as I described earlier. It is more prothrombotic than bleeding, right? But it is not like DIC. It is a different. So it is caused some peculiar coagulation abnormality caused by COVID infection, right? So what it could give rise to? It could give rise to both arterial and the venous thrombosis, causing DVT, pulmonary embolism, sometimes CVA, even acute limb ischemia has been reported. And that is why now the standard of care for more severe cases of COVID-19 is anticoagulation. This is, I was telling about ACE2 and the cardiovascular manifestation. With the time restriction, I'm not going to describe all this. The ACE2 is an enzyme. It is the basic biologic mechanism how the virus enters the host cell. And the SARS-CoV-2 infection is triggered by binding of the S protein and the AS, which I explained earlier. AS2 is highly expressed in the lungs, kidneys, heart, and the blood vessel. So this tells us why the COVID infection is affecting more of these organs, right? Why the lung has one of the highest concentration of AS2. SARS-CoV-2 infection might result in downregulation AS2, and which is, some say the real postulation is once the downregulation AS levels goes down on the cell surface, that is the one causes real problem to the heart and the lungs, rather than it really affecting the other way around. So the recombinant AS therapy has been, some research is going on whether to give the AS recombinantly as a medicine to treat the COVID-19. And the ACE and the ARP, which I said, the consensus is do not stop the ACE inhibitor or ARB if the patient gets the COVID infection, because this ACE gene is really not affected by this ACE inhibitor, so ARB. That is the reason, just to know about it. I talked about hydroxychloroquine and the azithromycin, again, which is now not the standard of care, but if we are giving hydroxychloroquine, azithromycin, we need to frequently monitor the ECG for QT prolongation. So living and working with the pandemic, I think we all know, as there's no proper medicines or vaccine as yet, we need to live with it for at least some longer period of time. And the pandemic is changing our lifestyle in an unprecedented way, and given the lack of safe and effective vaccine or medicine, we need to bear with it. We have to live with the virus. So the healthy behavioral changes, hand washing, mask, and those things are very important. And the effect of pandemic on social interaction, you know, this social interaction that we are facing. I'm talking to the chairs now with two, at least nice to see two ladies are sitting in front of me, but otherwise I'm talking to many chairs, right? And the reduced physical activity, which is again a problem because reduced physical activity can cause obesity and leading to cardiovascular disease. This is just for, again, completion's sake, what PPE for which situation. It is a very busy chart. I'm not going to say anything about this. But if anybody, I think later on for the website, you can go and find these lectures. So this is what to put on in which situation. I have put it up here. So these are the basic equipment that we are wearing, FFP3 and the N95 and their efficacy. And this is donning and undonning of PPE. That is very, very important to know as a healthcare worker how to do it properly, right? And I think that gave some message about COVID and cardiovascular disease. Thank you very much.
Thank you, Zaki. That was very comprehensive and timely lecture in this era of COVID-19. But still, unfortunately, I don't have time to go through discussion. And thank you so much.
Yeah, pleasure.
Okay. Okay, before moving into our final segment of this session, let me congratulate the winner of our competition to Tushari Balasurya, tushlakmali@gmail.com, and she won 10,000 rupees worth gift voucher. You can collect the voucher at SLCC office. Okay. Now, we are moving to the final segment of this session. So, I would like to invite Dr. Amila Valavatta, consultant cardiologist, to head the quiz program. Over to you, Amila.
Thank you, Desna, and good afternoon to all. So we'll be taking the next few minutes to discuss few questions. So let's start the first question. So this is the first question. So what is the target time given to do an ECG to diagnose a STEMI in an emergency setting, that is in the emergency treatment unit? So the first answer is 10 minutes, the next 60 minutes, less than 120 minutes, less than 10 minutes, and 60 to 90 minutes. So we'll give around 20 seconds for you to go through the responses and submit your answers. So we'll be moving on to the answer. So the answer is less than 10 minutes. That is, I mean, in a setting of STEMI, you would like to do the ECG as early as possible. So, so you would like to do it very quickly, as early as possible, but should not be more than 10 minutes. So less than 10 minutes is the answer for the first question. So next question, which medication does not have better mortality outcomes in STEMI patients? So mortality outcomes means, improving mortality outcomes means saving lives. So which medication does not reduce mortality? A, aspirin, B, morphine, C, bisoprolol, D, enalapril, and E, atorvastatin. So not a difficult question. So as you can see, aspirin will lower the mortality. Same with bisoprolol, enalapril, and atorvastatin, all will lower the mortality. So the answer is, they are moving. So everybody has got the answer for the second question. So the answer is B. The next question, a 52-year-old man with diabetes and hypertension on regular medication has chest tightness on inclines, and is relieved by rest. So he is on metformin and losartan. His blood pressure is 140/90, pulse rate 84, and the sugar is 110, fasting sugar, and the LDL cholesterol is 112. So the question is, which is the best management response? A, he should be started on aspirin. B, he needs aspirin and nicorandil as first anti-anginal treatment. C, he should be on aspirin, statins, and beta blockers. D, both B and C being correct. E, all of above incorrect. So we will wait for the poll response. Uh, so many got C and D as the answers. Actually, the answer is C, because aspirin and nicorandil, the B says are anti-anginals. Actually, nicorandil is anti-anginal, but aspirin is not an anti-anginal. It's an antiplatelet agent. So anti-anginal is to reduce pain. So anti-anginals we take as beta blockers, that is lowering the heart rate, will improve diastolic blood flow, hence will reduce angina. Then followed by the vasodilators, so GT and nicorandil, they are the anti-anginals. So aspirin is not an anti-anginal. So the answer is C. So he should be on aspirin and a statin to lower cholesterol and beta blockers. 3 essential medications. So the next question, a 60-year-old lady with hypertension and a past history of MI on regular medication was having recurrent leg cramps but no myalgia. She is also on treatment for gastritis. She is not on diuretics and her electrolytes and calciums are normal. If it's a drug causing her cramps, what should be the cause? Answers: losartan, bisoprolol, pantoprazole, aspirin and statin. So we'll wait for the polls. Many got E as the answer, but as statins does cause myositis. It can cause pains or aches in the muscles with CPK rise. But this is just cramps. The answer is actually pantoprazole. Proton pump inhibitors interfere with magnesium absorptions in the gut. So it will produce low magnesium levels, so hypermagnesemia will induce cramps. So cessation of PPI and then addition of magnesium supplementation will relieve the cramps. So it's about happens in about 1% patients on proton pump inhibitors. So the next question, which condition or complication in acute myocardial infarction can cause cardiogenic shock? A. Rupture of intraventricular septum. B. Acute MR. C. Right ventricular infarction. D. Ventricular tachycardia. E. All of above. And we'll wait for the response. So D and E is majority's answer. Actually, the answer is all of above. Rupture of intraventricular septum, acute mitral regurgitation, arrhythmias and RV infarctions are all causes for cardiogenic shock. So answer is E, all of above. So the next question, which one is not a drug or an intervention used in the management of cardiogenic shock? A. Dopamine. B. Norepinephrine. C. Dobutamine. D. diltiazem. E. Intra-aortic balloon pump. So we'll wait for the poll results. Many got D and E as the answer. Actually, IABP or intra-aortic balloon pump is useful in cardiogenic shock, but diltiazem is the answer because it's a drug which will reduce cardiac contractility, and so it will lower the blood pressure further. So it is not used in the management of cardiogenic shock. So answer is D. moving on to next question. This is the ECG. A 50-year-old previously healthy female presented with palpitation. She is conscious and rational. Blood pressure 130/80. Oxygen saturation is 95% on air. ECG is given below. What is the best treatment option? You can see a narrow complex regular tachycardia. So we'll wait for the poll results. Sorry. Drugs are IV verapamil, IV amiodarone, IV metoprolol, IV adenosine. E is DC cardioversion. The blood pressure was 130/80. Sorry, we'll wait for the poll results now. Yeah, everybody got that. That's a regular narrow complex tachycardia. So the answer is IV adenosine. Verapamil also can be used, but the first line of medication would be IV adenosine. In fact, carotid sinus massage is also an option. Medication would be IV adenosine, the first line. So answer is D. Next question, another ECG. 65-year-old patient with ischemic heart disease presented to OPD with chest discomfort and fainted while waiting to see the doctor. He was admitted to ETU and urgent ECG was taken. What is the next best option in the management? So you can see here broad complex regular tachycardia. So the answers: A, contact on-call cardiology SR for primary PCI, B, IV amiodarone, C, IV metoprolol, D, IV adenosine, E, DC cardioversion. We'll wait for the poll results. So majority got D, B and E as the answer. So B is IV amiodarone, E is DC cardioversion. So the patient collapsed, means that he was hemodynamically unstable. So the diagnosis of the ECG is regular broad complex tachycardia. So that is a ventricular tachycardia. So the patient is unstable, the treatment is DC cardioversion. If the blood pressure is stable, of course amiodarone is an option. But here, since he collapsed, the answer would be DC cardioversion. So the answer is E. Which statement is wrong regarding cardiomyopathies? A, viral infections, thyrotoxicosis, alcohol and chemotherapeutic agents are known causes of cardiomyopathy. B, in women with peripartum cardiomyopathy, subsequent pregnancies will not carry the risk of deterioration. C, ST segment elevation and rise in troponin levels are known to occur in Takotsubo cardiomyopathy. D, cardiac MRI is used to evaluate, that's a spelling mistake, evaluate the etiology of cardiomyopathy. E, hypertrophic cardiomyopathy is a genetic disorder. So we'll wait for the poll results. So there's a miscellaneous responses, majority pointing towards B. So that is the correct answer. Peripartum cardiomyopathy carries the risk of future recurrence in subsequent pregnancies. So patients need to be warned. And though in those who have no improvement in LV function, actually it probably is an indication for it probably is a contraindication for pregnancies as well. But those who have recovered LV function can have future pregnancies, but they need to be warned that there's always a risk of a further recurrence and sometimes further deterioration of the LV function. So the answer is B, peripartum cardiomyopathy can recur in subsequent pregnancies. Which of the following cardiovascular disease is or are known to occur in COVID-19? Think from Zaki's lecture. A. Myocardial injury. B. Atrial fibrillation. C. ST elevation MI. D. Pulmonary embolism. E. All of above. I think if we'll wait to see how people have comprehended Zaki's elaborative lecture. So majority of people have got the correct answer. It's all of above. So you get myocardial injuries, arrhythmias, all sorts of arrhythmias, ST elevation MI, pulmonary embolism, the thromboembolisms. So correct answer is all of above, E. The next question. Which of the following is untrue about COVID-19? Susceptibility to and the outcomes of COVID-19 are strongly associated with cardiovascular disease. B. SARS-CoV-2 use ACE2 as an attachment receptor to enter host cells. C. Hydroxychloroquine and azithromycin combination therapy is safe and effective against COVID-19. D. Elevated troponin is an independent marker for poor prognosis. E. The number of patients with myocardial infarction seeking urgent hospital care declined significantly during the pandemic. So the poll results. It asks about what is wrong, what is untrue about COVID-19. So the number of patients with MI seeking hospital care has declined significantly. That is true. That's a correct statement. So that's not the answer. We are searching for the wrong response. So the answer is C, because hydroxychloroquine and azithromycin combination can cause QT prolongation and lead to arrhythmia, especially Torsades D pointis tachycardia. So it's not a safe combination of medication to be used in COVID-19. Cardiac lesion with duct-dependent pulmonary circulation is A. Aorticopulmonary window, B. Pulmonary atresia, C. Interruption of aorta, D. Tetralogy of Fallot, E. Perimembranous VSD. So duct-dependent circulations means the pulmonary flow is dependent on blood flow through patent ductus arteriosus. So the response, the poll results. Could we have the poll results? Different people have got different answers. Actually, the answer is B, pulmonary atresia. Pulmonary atresia means the pulmonary artery is not developed. So you get complete occlusion of the pulmonary artery. So beyond that occlusion, the flow is dependent through a flow from aorta to pulmonary artery to a patent ductus arteriosus. So pulmonary artery is occluded. Beyond that, the flow will be diverted from aorta into the pulmonary artery by the aorta through the PDA. So pulmonary atresia is the correct answer. Pulmonary hypertension is an early complication of A. ASD, B. Pulmonary stenosis, C. Large VSD, D. Aortic stenosis, E. Tricuspid atresia. We'll wait for the poll results. Everybody got that answer as B. So pulmonary stenosis doesn't cause pulmonary hypertension. Pulmonary stenosis means the pulmonary outflow is narrowed, maybe due to some outflow obstruction or maybe due to narrowing of the pulmonary valve. So it doesn't produce pulmonary hypertension. Pulmonary hypertension happens due to obstruction beyond the pulmonary artery. So the answer here is large VSDs, which causes rapid development of pulmonary hypertension in early childhood. So it's very important to identify this defect very early after birth, so that complication could be prevented by early surgery within few months. ASDs does produce pulmonary hypertension, but it's not an early complication. It develops in the second decades or after that, or even the third, fourth, fifth decades. So the answer is C. Which one of the following statements is not true? Not true regarding peripartum cardiomyopathy. A. It is commoner among women more than 30 years old. B. It is common in women of African descent. C. It is rare before 36 weeks of gestation. D. It is common in multiparous women. E. Subsequent pregnancy is absolutely contraindicated once a woman develops the condition. Wait for the poll results. Yeah. Correct answer is E. Because as we elaborated in the previous question, the future pregnancies, it's not an absolute contraindication. Some people have complete recovery of LV function. So they need to be warned about future recurrence of peripartum cardiomyopathy. But if they take the risk with the understanding, they should be able to go through the next pregnancy. But those who don't improve the LV function, then it's an indication, a contraindication for future pregnancy. So it's not an absolute contraindication. If the LV function improved, then the patient can have, but then the risk of future recurrence need to be understood and to be explained to the patient in advance. So they are taking an explained risk. Which of the following statement is true regarding hypertrophic cardiomyopathy? A. Nitrates are used for symptom relief. B. Has autosomal recessive inheritance. C. Systolic murmur increases in the squatting position. D. Beta blockers are generally contraindicated. E. Echocardiography is the most useful screening test. All results. Yeah, majority got the answer correct. Echocardiography is the most useful screening tech. Beta blockers are in fact used in the treatment. It's autosomal dominant, and the systolic murmur would reduce in the squatting position because the afterload will be reduced. So majority got that correct. Next question. Which one is the wrong statement regarding heart failure? A. Normal plasma BNP level, that is brain natriuretic peptide level, does not exclude heart failure. B. Tachycardia is one of the early signs of heart failure. C. Heart failure cannot be excluded if ejection fraction is normal on echo. D. Heart failure can cause abdominal pain. E. Diuretics improve symptoms of heart failure. So look for the poll results. The answer is actually A. Nobody has got the correct answer because plasma BNP is very sensitive. So if the BNP level is normal, it is not heart failure. So it does exclude heart failure if the BNP levels are normal. Tachycardia is an early sign. EF normal, still you can have heart failure, which is we call heart failure with normal EF due to diastolic dysfunction. Heart failure can cause abdominal pain, that is true, because of hepatic congestion. Diuretics can improve symptoms, that is also true. So the wrong answer is A. Next one. So we'll wind up after this question because the time is up. So which is not advisable in heart failure? A, salt reduction. B, I would like to modify the second response. Actually, it should be prolonged bed rest. C, water restriction. D, monitoring of body weight. E, reduce or manage stress. We'll wait for the poll results. Sandamali, do you want to continue the questions or finish it here or at the? So majority got it correct. Prolonged bed rest is not advisable because it can cause, stagnation of blood leading to deep vein thrombosis and complications as a result. But bed rest may be, a limited prescription. For example, if someone has, pulmonary edema, class 4 heart failure, then maybe a day or two of bed rest may be advisable, but not prolonged bed rest can lead to DVT. As time has elapsed, I would like to thank you, Sandamali, for the opportunity and this. Thanks.
Thank you, Amila, for trying to keep things interesting in this virtual session. So we have come to the end of today's session. This is actually a very new experience for us, trying to do this all fully virtual. If there were any shortcomings from our side, I would like to apologize humbly for that, because this is our first experience, so we may have made some mistakes there. And I hope you all have gathered something out of this today's sessions. First of all, let me thank all the faculty members for being here today, despite the situation in the country and despite your busy schedules. And we really appreciate your presence and your effort in trying to make this session successful. And I would also like to thank President and the Council of Sri Lanka College of Cardiology for your unwavering support for both of us to get this program for allied health professionals successful. And also, I would like to take this opportunity to thank our audiovisual team and the staff of the hotel for your unwavering support and making this event successful. Last but not the least, I would like to thank all the very highly enthusiastic participants from all over the country. Because of you, we made this day successful. And I know you always have been very enthusiastic and keen to participate in our program. And I hope you will continue to give that support to us in future events as well. So thank you so much for all our nursing staff and all our allied health professionals for participating today. And so we have come to the end. Thank you so much. I hope to see you all next year also in COVID-free world. Thank you so much.